to open the mics. He said this would be better for interaction. Everyone can open the mic. You know what the problem, Dr. David? I can do that for you for 1 hour, okay? But you will be the first one to tell me, please close it. Because what's going on, without you notice, anyone will open his mic, will go out and come back, and his mic will be open. So there will be a kid's voices, there will be a house, there will be a very noisy background. So usually this is the problem. If you want to ask anything, just raise your hand in the chat list. I will just open your mic anytime you want. But he can't give the ability to open. Every 5 minutes, someone will open his mic by mistake. Okay, Dr. David, you get that? You see, Dr. Wafi said my kids around me. So Dr. Wafi will start by the background noise. Okay, so because usually start to open by mistake. Perfect, Dr. Adam. I like your performance very much. Okay, and again, you are one of the persons that I know you will be a top scorer, because if this is your start, so by the end you will be more than perfect. Okay. Inshallah. Okay, so good luck. Now it's the time for the break. 15 minutes. 15 is okay, right? Because we have a lot of topics to discuss. Today is a long day, but not a heavy one. So 15, vote. 15.
20, Victor.
20 is too much, Dr. Adam. We can take extra keys in this 5 minutes. So I think 15 is okay. They all agree with 15, Dr. Adam, okay?
Okay,
so good luck, my friends. See you. Now, in your time, it is 9:20, so let's come back 9:35, okay? Inshallah. Assalamu alaikum. So now, Dr. Shazia, can you try your mic, please? I will open your mic. Oh, Dr. Shazia is not here yet. Oh. Okay, Dr. Shazia is not here yet, so we'll go to the next doctor. Oh, Dr. Shazia is here. Okay.
Hello?
Yes, I can hear you now, Dr. Shazia.
Yeah, okay, thanks God.
Okay. So you have a good connection?
You're good now.
Mm-hmm. Okay. So the next case, ready?
Yeah.
Inshallah. So this is Mr. Karim Azal. He's 48 years old. And you are going to see Mr. Karim Azal. This is history. And he gives a history, 4-month history of knee pain and swelling. Knee pain and swelling. Routine blood test show ALT of 108, AST of 114, creatinine of 0.7, bilirubin 2.3. He's diabetic and his diabetes recently uncontrolled. Please see and advise. This is a history case. You have 2 minutes. Doctor.
Okay.
I need everyone to write his differential for this case. Okay, can you start, doctor?
Yes.
Okay, so let's start.
Okay. Hello, is it Mr. Karim Azal?
Yes.
And you're 48 years old?
Yes.
I'm Dr. Kamal and I'm doctor on duty here today in medical admission unit. How are you today, Mr. Karim? Okay, I got a letter from your GP mentioning that you are having some problems with your health. So we are here to discuss about that. So can you tell me about what is happening?
Yes, doctor. I'm suffering since 4 months of this knee pain. And it was responding to painkillers. But recently, the pain become very severe. And I noticed that it's swollen.
Okay.
Mm-hmm.
Okay, so you're having pain for 4 months, right?
Mm-hmm.
And now you are having some swellings. So anything else with this pain?
What do you mean?
You have just pain in your knee joint.
Yes.
Pain anywhere else?
Yes, sometimes, doctor. Sometimes I have pain in some other joints. Sometimes.
Okay.
But the knee pain is the severest.
Okay. Okay. I'll ask about all those. It's in one knee or both?
Yes, it's one knee, doctor.
Okay. And that pain started 4 months ago. Is it continuous since then, or it's comes and goes?
Yes, it is continuous. When I take the painkiller, it improves, but after a while, it's getting worse.
Okay. Do you remember anything happened just before you started having pain? Any trauma to your knee or anything else?
No, doctor.
Okay. And so can you grade the pain on the scale of 1 to 10, as 10 is the worst pain you can ever have?
6, doctor.
Sorry?
6 over 10.
6? 6 is all the time?
With the painkiller, it's gone down to 2.
Okay. And what time of the day you have pain?
Every time, every time you didn't take the painkiller.
Okay. Do you feel the pain is more at morning or more at night after evening after activities?
Yes, I can't do any activity because of it.
Okay. Do you feel better with rest or?
Little bit.
Little bit. Or you feel, is there any change with any activity? You said
you can't do activity, doctor, because of the pain. Yes.
I'm sorry to hear that, and I will try my best to help you out with that. So that pain only stays in your knee, or it goes upwards or down in your leg?
Yes, mainly in my knee. Doctor.
And do you feel any stiffness in your knee joint?
Not really, doctor.
Okay. So and you're also telling me that there is a swelling of your joint.
Yes, it is swollen, doctor.
Okay. And the swelling is for the last 4 months, or is that recent changing?
The swelling, it's increased in the last month. It's more than before.
Okay. Do you feel any redness over the skin?
Little bit.
Okay. And do you feel warmth? Warm?
It is a little bit warm, doctor.
Okay. Is there any increase in your body temperature?
No, doctor.
Okay. And okay. Or you're telling that only painkillers makes your pain better. Anything else?
No.
Okay. Or anything that makes your pain worse?
As I told you, the activities. You're doing any activity. I'm trying to take rest all the time.
Okay. Do you feel any? And this is the first time in your life that you're having this pain, or do you have any previous history of such illness?
For what? For the knee, you mean, or in general? I have diabetes.
In general.
I have diabetes, doctor.
No pain. Any pain in any other joint?
Pain. As I told you, sometimes I have a different pain in different joints, but not as severe as this one in my knee.
Okay. And what other joints are involved?
I had sometimes elbow pain. I have sometimes pain in my wrist.
Okay. Is there any swelling with pain over those joints also?
No.
Okay. So you have diabetes.
Yes.
And it is also mentioned in your GP letter that is not well controlled now.
Yes, it's not controlled. Actually, I was diagnosed with diabetes since 2 years, but it's never controlled.
Okay. What you are taking for diabetes?
I started with metformin. Okay, and then they add 2 other medications. I can't recall the names, but eventually he put me on the insulin.
So how much insulin you are taking right now?
I'm taking the Actorabid 3 times a day based on the reading, and I'm taking the long-acting at night, 20 units.
Okay. And when did you check your blood sugar last time?
I'm not checking regularly, but my last A1C was 10.
Okay. And when was that?
It was 1 month ago.
Okay. Okay. Anything else in your past medical history?
That's it, doctor. I have this diabetes.
Okay, are you taking any other medications besides this diabetic medicine?
No.
Okay. And you were telling that you take sometimes painkillers for your knee pain?
Yes.
Okay. How often do you take those painkillers?
I'm taking it twice daily.
Okay. And you feel a little bit better with painkillers?
Yes, for a while, then to become again.
Okay. Okay. I will ask some questions about your health in general, and about some question about your family history. Do you have any person in your family that has the same problem with joints?
I'm adopted, doctor.
Okay. Okay. So how's do you have any history of any yellow discoloration of your eyes?
Yes, doctor. I noticed that, and I told my GP about that, and he told me that he's going to send some blood works. And when he said that, he told me that it came abnormal, and that's why he sent me to your office.
Yes, I can see that. And do you have any discoloration or any change in your skin color recently?
Discoloration?
Yeah. Any change in your skin color?
Yeah, it's become more dark.
Okay. For how long you're having that?
I think in the last 2 or 3 years.
Okay. And do you have any pain in your tummy?
Pain in my tummy a little bit sometimes.
Okay. Have you ever noticed any swelling in your tummy?
Swelling?
Yes.
A little bit. I feel it's a little bit swollen.
Okay. Do you have any problem with your appetite?
With my appetite? No, my appetite is okay.
Any change in your weight?
No, I think this is okay.
Okay. Any feeling of nausea or vomiting?
Sometimes I feel sick.
Sometimes. Any change in your bowel?
Bowel motion? Not really.
Have you ever noticed any change in color of your stool?
I didn't. I'm not sure. I didn't watch that.
Okay. Any problem with your urine?
Not really. I think it's a little bit darker.
Darker? It's darker, dark yellow color or any redness in it?
Darker. Going to be nearly like a tea or more dark yellow and a little bit frothy.
Frothy. Okay. Any swelling in your feet?
My feet? No.
Yeah. Okay. Any problem with your breathing? Any shortness of breath?
Shortness of breath? No.
Any history of any chest pain?
Chest pain? No, it's not chest pain.
Okay. Or do you feel any problem with your eyes?
Just the color. It looks more yellow.
Okay. Any vision problem?
No.
Do you go to your eye doctor regularly?
No, doctor.
Okay.
No.
Okay. And Mr. Hasan, what do you do for your living?
Yes, doctor. I'm an accountant.
Okay. And who else is living with you at your home?
Actually, I was living with my girlfriend, but she left me.
I'm so sorry about that.
What?
Sorry for that.
Thank you, doctor.
Okay. Have you ever been admitted in a hospital before?
Admitted? No, doctor.
Any drug allergies?
No, doctor.
Okay.
2 minutes remains, doctor.
Okay. Do you smoke?
No, doctor.
Do you drink?
Drink what?
Alcohol?
Alcohol? No, doctor. Actually, yes, I'm drinking.
How much do you drink in a week?
I'm drinking about half bottle of whiskey every day.
Oh, it's too much for you, Doctor, Mr. Hasan.
Yes, I know, but I'm living alone and I'm very depressed.
Yeah, well, we will talk later about it. How you can try to quit this. And Mr. What are your concerns for today?
I want to know what's going on with my knees.
Okay.
And, is it something serious? And the other thing, what about this? He told me my lab work is not normal. So is there something serious I should worry about?
Definitely, we will discuss about that. That your tests that are showing that you are having some problem with your liver too. And when we put all these things together, there is a one genetic condition that can cause all these problems. But we need further some your complete examination and further investigation. We will go for an abdominal ultrasound and to look your liver size and texture. And maybe we can go for some genetic testings, or if we need, we also we can go for liver biopsy for that to diagnose. And for your knee pain, we will give you some good analgesics, and I will also refer you to a physiotherapist to get some physiotherapy for your pain. That
what's my problem?
Sometimes it's we will when all the tests will come, then we will definitely sit together and we will discuss about the diagnosis, and we will be having a confirmed diagnosis of your condition.
Time finish, doctor. Time finish. So
okay.
It is the examiner time. Thank you, doctor. It's the examiner time. Then we will discuss.
Okay.
Give Dr. Rashid a score. Dr. Adam, give you the full mark.
Oh, thank you. It was my first practice.
And Dr. Wants give you full mark, and other doctors give you between 15 and 20.
Also nice of you, all.
There's one doctor changed his mind. Dr. Johnny said something. Scores. Okay. Okay. So out of 20. Okay. So let's now ask him the questions. What's your differential diagnosis?
My first differential diagnosis is hemochromatosis.
Yeah.
No.
Hemochromatosis. The examiner will not say tell you yes or no. And the examiner now.
Okay. So you say no.
No, I didn't say no. They say okay. Then. Hemochromatosis. What's the other differential you have?
Definitely. Then after that, as the patient is having knee pain and swelling, we would also like to rule out the causes of pain, pseudo-gout.
Hemochromatosis causing pseudo-gout.
Yeah, it causes.
What else?
And osteoarthritis.
Osteoarthritis. What else?
And septic arthritis, but
arthritis, good.
But patient didn't mention any fevers. But
Well, I agree with you.
yeah,
I agree with you differentially. Okay.
but I was actually looking all these things, so I thought that hemochromatosis would be the first one. So,
Yeah,
but
but
definitely, I would like to rule out septic arthritis as patients having knee pain and swelling.
yes, that's doctor. You need to prepare yourself for differential and the differential, including the correct one, right? So
Okay.
you can't say it's only hemochromatosis. You need to give 3 or 4 differential. Then the right one is one of these. Put on the top the one you are sure of. Okay. This is something to think about in the minute they are giving you between the case and the questions. In the minute they will say, I'm going to give 1, 2, 3, 4, and on the top I will say that. The other thing, what are other features or symptoms of hemochromatosis you need to care about?
In hemochromatosis, patient can develop liver cirrhosis and hepatocellular carcinoma.
Yes.
So we need to look for that. Patient can have signs and symptoms of chronic liver disease with that. So we need to address.
What else?
What else?
What else? What else?
Cardiac.
Cardiac.
Patient can, yeah.
You can develop heart failure, right?
Yeah.
Okay.
I asked that about shortness of breath as well.
Yes, you did. What else?
And
Why
patient.
why do you think he left his girlfriend?
Sorry. Yeah. I forgot to ask about her sexual problems. Erectile dysfunction is.
It is a private issue. We don't need to discuss with the patient.
Okay.
No, we should discuss it. I mean, when he told you something like that and it is related.
Okay. Yeah, actually, that point missed. It was not in my mind at that time. So
yes.
That's right.
Under stress. So you asked about the there is hyperglycemia, there is hyperpigmentation, there is hypogonadism, there is hepatic cirrhosis, and there is heart failure. But we did the summarization. Why nobody summarizes? You know, when you summarize, you help yourself because when you summarize, you collect your thoughts. You tell, hey, say, so Mr. Kareem, let me summarize. You are suffering of knee pain. You are suffering from knee pain. That started since 4 months, and the swelling that started since 1 month. And you were diagnosed. You were diagnosed with diabetes since 2 years, which is never controlled. Okay, although you are taking your medication. Okay, and you're adopted, so we have no idea about your family history, correct? Okay, and you notice that you have a yellow eyes, and your doctor found that you have some abnormality in your lab works, and we are here to discuss it, correct?
Okay.
And you left your girlfriend, and you are living alone now, and you have some problem with intimate relations, and if he told you that for sure. Okay. And you notice that there is a pigmentation, so you are collecting your thoughts, and you are showing the examiner that you asked it about everything, and you collect the threads together to give the answers, right?
Okay. Yes.
Then can you tell me what's your concern? Do you want to add something? Did I miss anything, Mr. Kareem? No. Okay, yes, that's it. Okay, so can I know what's your concern? So please, doctor, try to remember summarization is very important, and it helps you to collect your thoughts. Sometimes you didn't reach the diagnosis yet, and when you collect everything, you will remember that you didn't ask about the hypogonadism, for example, and this stuff. Okay, right? So summarization is important. Here, my comments only I wrote that the sexual history you didn't ask about in detail, and you didn't summarize. Okay, your differential need to be strong. I mean, you give a correct, but don't give only hemochromatosis and stuff. Say hemochromatosis, septic arthritis, osteoarthritis, as you like. Hemoarthrosis, whatever you want to say.
Okay.
Just give him some related differential and put against. If he told you what against this one, what against this one, you can answer him. Okay.
Okay.
You did well, doctor. You did very well. Again, you catch the diagnosis. I don't want you, examiners, I don't want you to be tough in yourself. This is not true. If the patient catches that the knee pain is related to pseudogout, and pseudogout coming from hemochromatosis, okay, this is a very good performance. Okay, this will give here 18 or 17 over 20. So the other things you will do will be for perfection and advising the patient and this stuff. Okay, this will be for perfection. Okay, alcohol is important. Okay, the things that I didn't like your description to the patient. Please don't try to make it very vague to the patient. The patient asking you the answer of we are going to do 1, 2, 3. This is not the answer for the concern. The answer for the concern should be a disease. If you asked about the disease. Now I'm thinking about one disease called hemochromatosis. Let me describe it. Hemochromatosis is a disease at which there is abnormal, deposition, or the body can't get rid from enough iron. So there's more iron in your body, trapped in your body, and start to go and affect different places in your body. It can affect your liver and causing liver problem, can affect your joints. So the patient will go out expecting what's going on, expecting the complication that he hears from you, right?
Okay.
But don't get this answer. We are going to check. This is not an answer. This answer is when we don't have any answer. Okay, and usually the examiner will count it. You didn't solve the patient's concern. So you got the answer and you didn't answer the patient's concern for unknown reason. I don't know why you didn't answer him because you got the answer. So you can link the things together and then tell him this is abnormal deposition or abnormal content of the iron body. The body can get rid of the iron in it, and they start to split in different area and start to cause multiple symptoms of 1, 2, 3, 4. We're expecting this, expecting that. We need to follow with 1, 2, 3. So we get the full. You get the full on that, especially when you ask the impact also about the life, and that's it. You agree with me?
Yes.
So did you write my comments? I want everyone to write the comments that I give to the performance. So next time when he practice, you know that he will not do the same mistakes, right? Okay. You did very well, by the way, doctor. I like your performance very much. Okay.
Thank you. Thank you so much.
Thank you, doctor. Good luck. So I'll close the mic. Sorry, doctor. This is the hemochromatosis. Sorry. My mic closed. This is the slide of hemochromatosis. As I said, arthropathy plus 5H, hyperglycemia, hyperpigmentation, hypogonadism, hepatic cirrhosis, and heart failure. And for the reversible, what is reversible in hemochromatosis? The skin color and some cardiac complication. But most of the other things is irreversible. The liver affection is irreversible. The hypogonadism is irreversible. Okay. Okay, doctor. So in what you are going to do, we're going to do iron study, liver biopsy, genetic testing, and MRI for the heart, and then we do phlebotomy as a treatment. You don't need more detail. That is enough for these details. Okay. So let's go back. This is for the hemochromatosis. Let's go back to the knee pain. I need you to focus now. Wake up. Remember, the base of the algorithm we used was the one for the back pain. We will keep adding things for every type of joint pain. Okay, so for the knee pain, you will start asking the same question: any stiffness or laxity? So here we add something very important to ask this question. You can even ask it in the back pain. Okay, any stiffness or laxity? And again, if you didn't ask about laxity, you will miss some cases. Okay, so for example, in the case of Ehlers-Danlos, and I know some candidates that lost the case of Ehlers-Danlos because of that, because they have patients coming with joint pain. They kept asking everything, and the time finished before they reached the diagnosis. Although only if they asked the question about the laxity, they will reach the diagnosis in first 30 seconds. Okay, so very early you need to ask any stiffness or laxity. If you want to add this question to the back pain, also I agree. So if the answer for increased laxity is yes, I have a lax joints, I have recurrent dislocations, you will think about Ehlers-Danlos, pseudodenoma elasticum, and Marfan syndrome. Okay, there is another group with recurrent fractures, and there is another group. I don't want to overwhelm you now with these, but remember Ehlers-Danlos, pseudodenoma, and Marfan syndrome. Okay, this is for the question of any hyperlaxity. Then I'll ask about stiffness. Let's continue down. Does it improve with activity? And as usual, presence of stiffness and being approved by activity. Okay, this going with inflammatory. And remember here you need to ask about other joints and BND, 3S, and rash. These questions are very important. You will ask them the same as the back, the same as the hand pain, the same as the knee pain, the shoulder pain. So remember, this group is fixed. You will keep it for any joint pain. Okay. Then you will go to ask about stiffness, and here there is some difference. There is extra step if compared to the back pain. We ask it, and there is a stiffness. I need to know the duration of the stiffness. The duration of the stiffness. Okay. Here, the duration of the stiffness is written in the algorithm less than 1 hour and more than 1 hour. And this is not exactly what I mean. You can't ask it by 1 hour. You can just ask how long it is. So if the stiffness extends for the whole morning, for example, okay, take the full morning. Okay, this is going with the seropositive. So let's say that the patient told you that the stiffness extends for 3 hours all the morning. So this is a serious thing. Okay, sorry, this is seropositive. When it is less than 1 hour or not less than 1 hour, just take when the patient takes a shower or takes breakfast and the stiffness improves. This is going with seronegative. So the stiffness duration in the seropositive is longer than in the seronegative. It is not sharp each 1 hour. I just put it as an example, but it should be like when the stiffness starts. Is it improved after your shower, after the breakfast, or it takes all the morning with you? Okay, if it's extended from 8 to 12, for example, this is going with the seropositive. And something to remember: I have no problem if you are going to ask about both pizza. If you are going to ask about the blue pizza and the red pizza. So if the answer is not clear, you can't assume that it's not seronegative only because the stiffness you are not sure if it's long or short. I would never end on that. Once it is inflammatory, I will ask about both pizza. This is what I will do myself. Okay. So the blue pizza simply this patient coming with a knee pain. How are you, sir? We are here to discuss blah blah blah. Then I went for Socrates. So Socrates should be there. You ask it the Socrates, and then you ask it about any stiffness. Okay, and or any laxity. Yes, there is a stiffness. Did you notice that this is improving with activity? Yes, a little bit. When I start to move, I forget the pain, or the pain improve. Okay. Do you have any other affected joint? What about rash? Do you have any rash, any swelling, any depending on what you have? Okay. So PND will ask about the knee itself, not only the other joints. You'll ask about deformity. You'll ask about other joints. You'll ask about the pain. You'll ask about if there is a swelling. Okay, and if there is asymmetrical affection, then we'll ask about rash. So this box is super important. Then you will go to the laxity. No. Stiffness. Yes. Duration. Then I will ask: do you have any back pain, shortness breath, eye problem? Okay. Frothy urine, pain in the back of your feet. Okay. Any rash, any nail change, any sores in private area and in the mouth, any history of blood clot. Do you have any history of infection, difficulty in urination, or in making urine? Okay, do you have any lost motion, blood coming with the back passage, abdominal surgery? So these are the blue pizza. Then we'll go to the red pizza. And here remember, this is the seropositive. Always remember, the red is positive. So the red circle, we will have rheumatoid arthritis. So I'll ask about any hand joint pain, any deformities. So hand joint pain and deformities. You always remember that the red circle is associated with, even the blue circle, they're associated with 3 main things you need to ask about. You need to ask about lung affection. You need to ask about kidney affection. You need to ask about heart affection. So usually ask in general, beside the joint pain, about any shortness breath, any heart racing, and any frothy urine or change in the urine. Okay, so these are general because rheumatoid, usually all these diseases will be affecting the kidney or will be affected the kidney or will be affected the heart. It can be affecting the lung. Okay, so remember, rheumatoid arthritis, you will say, do you have any joint pain, shortness of breath, awareness of heartbeat, lumps and bumps because of the rheumatoid nodules, for example, frothy urine because of the kidney affection. Systemic lupus, again, this is just a screening question. Don't go in detail. Don't go in details. The SLE, ask about mouth sores, ask about joint pain for sure, ask about frothy urine, ask about rash in area exposed to the sun. So this is systemic lupus. Then Sjogren syndrome, SS, write these names there. The Sjogren syndrome, ask about dry eye, dry mouth, joint pain. Systemic sclerosis, ask about tight skin, difficulty in swallowing. For all these, ask about changing in the color or pain on the tip of the fingers with changing in the color in response to cold weather. Some of you just link the Raynaud's to the systemic sclerosis, and this is a big mistake. Raynaud's happen with any seropositive problem. So, joint pain in the hand, frothy urine, shortness of breath, awareness of heartbeat, mouth sores. This is what you need to practice. Mouth sores, rash in area exposed to the sun. Okay, frothy urine we said. Then dry mouth, dry eye, tight skin, difficulty in swallowing. Okay, change in pain in the tips of the fingers. Okay, especially on the cold weather. Then pain on touching or pressing the muscles. Rash around the eye for dermatomyositis, erythroid rash. Then history of recurrent miscarriage and blood clot. This is going with APS, which antiphospholipid syndrome. Antiphospholipid syndrome. So if I want to ask about the 2 circles, it will take me less than 2 minutes. If I practice that very well, I will exclude all the inflammatory cases and causes, or I will catch it immediately. Okay, remember, it is not enough to reach any one of these. Okay, it's not enough to reach systemic lupus and I'm done. Because systemic lupus, if you said it's systemic lupus and you found that there's a tight skin beside the systemic lupus, so this is mixed connective tissue disease. And it's a different pathway, a different management plan. There is a case in Egypt coming in different way. It can come, sometimes they bring the patient as systemic lupus, sometimes they bring the patient as systemic sclerosis, sometimes as a mixed connective tissue based on what they tell the patient to say. Okay, so never stop. As I told you, don't stop when it is ankylosis because it could be psoriasis, and don't stop if it is systemic lupus or rheumatoid arthritis because it could be mixed connective tissue disease. So once we start the pizza, no diet. Eat all the pizza, okay? So please, whenever you start, don't stop till you finish the pizza because of the mixed connective tissue disease you may miss. And please, another common mistake, don't consider having one seronegative and one seropositive or the possibility of both as a mixed connective tissue. So there is nothing called that psoriasis with rheumatoid arthritis. So what's your differential? I'm saying mixed connective tissue disease because they are two. The mixed connective tissue is presence of positive, seropositive conditions together. Usually, it doesn't include rheumatoid arthritis, although it can. But usually, the mixed is systemic lupus with systemic sclerosis or dermatoid or polymyositis. But it still can come with rheumatoid arthritis. Okay, so this is what I mean. Why is it important? Because the anti-RNP is an investigation you need to do, and because this is one of the indications to give steroids to the patient with systemic sclerosis. Patient with systemic sclerosis, usually, we are not giving them steroid unless there is mixed connective tissue or there is severe lung fibrosis and they want to give steroids. But steroids is not part of the management of the systemic sclerosis, actually, unless it carries the criteria of these two. Okay, so this is the right side. Give me the okay about the right side of the knee pain. Okay, give me the okay and give me if you feel confident to go through that on the right side. Give me the okay. I need to see 24 okays there because this is super important. I will send you the list. I think Dr. Wafi sent you a list of how the cases that came in the exam, how many cases came for rheumatology cases. Okay, it's a very good percentage, maybe 9, 10%. So 10% of all the cases is rheumatology, and it is that simple as I'm telling you. So you shouldn't miss one mark in these cases, right? So now instead of going to the station or going to your time, spending the time reading about rheumatoid arthritis, reading about systemic lupus, everyone by its own, and then when it is in the exam, you will totally miss it. Now at least you feel confident that I have a map to follow when I go inside the station. Okay? Okay, so now let's move to the left side. Let's move to the knee pain. On the left side, when there is no stiffness. And as I told you, sometimes the answer for the stiffness is not enough, but the patient tells you that I'm improving with rest and I'm suffering with inactivity, for example. Okay, so you try to have double things. Sometimes I would, if I am in the exam and I didn't find any yes answer on the inflammatory, even if there is a stiffness, I will jump to the left side. What's the problem? I will exclude everything. I will exclude all the differentials. It's not a problem. I can do that in 3 minutes. Okay, so I found that there is no stiffness. Okay, so stiffness, no. So I think it is mechanical. Okay, it is, if it is gradual, it will be something like overuse and overweight and this osteoarthritis. Okay, but they can't say osteoarthritis before excluding the other things. I mean, I need to exclude trauma. So patient who's playing tennis, when they are 50, they start to have osteoarthritis. They have a chronic osteophytes. There is osteophytes and there is friction. There is a loss of the joint space. So there are many criteria for osteoarthritis. For the, if it's acute or coming as a sudden pain, recurrent, severe pain, I will consider trauma. So ask about history of trauma. Ask about fever and history of infection and hotness, redness of the knee. Then osteoporosis. Osteoporosis as a cause of knee pain, because osteoporosis causes pain anywhere. So again, the same question: increase weight, decrease weight. The same as the back pain, previous fracture, post-menopausal. So all these can cause a knee pain. Then crystals, and here I want you to start writing. Crystals, it could be uric acid, and it can be calcium. If it is a uric acid, so I'm talking about gout, which is usually not affecting the knee. It can affect the ankle joint, can affect the first metatarsal. The most common area at the bottom of the big two. But remember, whenever uric acid, ask about skin rash because of what? Psoriasis. Look at that, mixed connective tissue disease. This is the answer to your question. So for the gout, ask about rash for psoriasis. Ask about lube. Ask about water bells. Water bells for diuretics. So water bells and psoriasis. Ask about rash. Ask about alcohol. And ask about the food nature. Patient who's eating a lot of red meat, they have more uric acid. Ask about lymphoma. Ask about bundle one or any treated disease, chemotherapy. Patient who receive chemotherapy for leukemia or for lymphoma, they will have gout because of the high catabolic uric acid outcome. So psoriasis, diuretics, alcohol, food, and lymphoma. There is genetic, which is Lesch-Nyhan syndrome, but this will not come in the exam because the patient have mental retardation, microcephaly, seizures, and different with gout. But actually, psoriasis, water bells, alcohol, food, and lymphoma. For the pseudo gout, there is a lot of causes of increased calcium. So any case of increased calcium can cause pseudo gout. The TB can cause pseudo gout, right? So ask number one. Sarcoidosis. How to ask about sarcoidosis? Shortness of breath, rash in the chin, the tibia. You can ask coughing. You can ask the symptoms of hypercalcemia, excessive thirsty, polyuria, tummy pain, depression, constipation. So all these can be hypercalcemia, can cause any sort of gout. Hemochromatosis. This is our case today. Diuretics, dark skin, chronic liver disease, impotence. Then thiazides. Remember, thiazides increase the calcium in the blood. Usually you was learning that way. Thiazide, in Arabic, thiazide. So thiazide calcium. So thiazides increase the calcium in the blood. Very important to remember the hyperparathyroidism as a component of Men's syndrome. So Men's syndrome may be associated with hyperparathyroidism. So it causes hypercalcemia and pseudo gout. And Men's syndrome may have acromegaly, which also associated with pseudo gout, including hypercalcemia and pseudo gout. And sometimes the acromegaly itself causes osteoarthritis, associated with osteoarthritis. So for the pseudo gout again, increased calcium can be TB, can be with sarcoidosis, can be with hemochromatosis, can be with thiazides, can be with men. Then cancers. Okay, cancers. You need to add the cancers, or the cancer can cause hypercalcemia, including multiple myeloma, which is associated with hypercalcemia. Okay. Remember that HIV is an infection, and HIV can cause septic arthritis. Okay, doctors? So again, knee pain, stiffness. Tell me about this pain. The site, the onset, the course, the duration, increasing, decreasing, associations. Any stiffness, any laxity, does it improve with activity, any rash, any deformity, any swelling, is it symmetrical? Okay, then tell me about the stiffness. Is it more in the morning? Okay, when it ends, it takes all the morning with you. Okay, then can you tell me if there's any shortness of breath, any back pain, any rash, any nail change, any ulcers, any sores in the mouth or genital area? Okay, any difficulty in water work or in urine? Okay, any problem with back passage, blood? Then, John, as we said, in the speeds on the right side, on the left side, there is no stiffness. I would ask any history of trauma, any history of high fever, high body temperature, okay, with redness, hotness, okay, of the tenderness of the joint, okay, osteoporosis, as I told you, the risks. Crystal asked about gout and pseudogout. Then the last question about hemoarthrosis. Besides trauma, what can cause hemoarthrosis? Remember here, what to ask. Tell me in the chat box. What to ask for hemoarthrosis? What to ask for hemoarthrosis? Right in the chat box. No, not seven question of the, not seven question. The 4 questions of bleeding. Yes, I agree. So, Dr. Madonna, not the 7 question of clotting, the 4 question of bleeding, which are your personal history of bleeding, other bleeding. I mean, if the patient has bleeding from knee or hemoarthrosis, I'll ask about other bleeding. Maybe the patient have back passage bleeding, have epistaxis. So this confirms the tendency of bleeding. So, and then family history of bleeding. Patient with hemophilia, they have hemoarthrosis. Then patient on blood thinning medication. Patient taking high dose of warfarin. Anything can bleed because he has a high bleeding tendency. This is your knee pain algorithm. It can work also. You can use almost the same in the hand with some extra words, but usually the same things. The same things. The same right side, the same left side. Okay, it's not no big differences. It will not happen hemoarthrosis in hand of the joints, but anything else, septic, osteoarthritis, crystals, trauma, okay, and osteoarthritis, and all the right side can happen with the hand pain. So now hand pain, okay, hand pain and left pain, both of them, and knee pain, both of them can share the same algorithm. Okay, that's it. So let's go to the next case. Dr. Madonna, very early to say that. It's very early. What I can promise you that the tough part, or I mean, we will not say a lot of new things, okay, but we still have a lot of things to discuss. So it's impossible to say we will stop still. Yes, the osteoarthritis point, you will just ask about if this pain, you will exclude everything else. You will for osteoarthritis, exclude everything. Okay, then go to the if the pain is gradual, okay, and the patient overusing. Ask about what the job of the patient. What's your hobby? He's playing tennis. He's overusing his knees. He gained more weight recently. So all these are risk factors. You will not say osteoarthritis before exclusion of other things. So osteoarthritis you will say it eventually because it will be diagnosed by examination, okay, and by X-rays after exclusion of anything else. So you just go through the algorithm. Then you ask, what's your job? You gain more weight recently. Okay, do you overuse your knee? Do you think you overuse your knees? Do you have any recent imaging for your knees? And then you tell him it could be. Okay, it could be what we call osteoarthritis when there is a problem in the space in the joints, and you start to show him what I mean when the space between the 2 joints is lost and the fluid that lubricates the area in between become lost. Just describe to the patient. APS, doctor, referred to antiphospholipid syndrome. Okay. Oh, so now Dr. Sahar, I don't know exactly because every country say the name in a different way. We have Dr. Sahar, Dr. Ibrahim, Dr. Amr. So Dr. Sahar, are you there? Still awake? Hey, my friends, why I feel you're weak today? So I need more power. Okay, I'm getting my power from you, so please. So Dr. Sahar, there is 2 Dr. Sahar. Did you log in with the 2 devices? Which one to open? Do you have 2 Dr. Sahar in the course? I will open 2 mic and please introduce yourself. Now I have 2 Sahar mics open. We have 2 Dr. Sahar?
Yes.
So who's Dr. Sahar want to practice today? So give me anything to differentiate. What's your second name, doctor?
Yes, I'm Dr. Sahar Abdul Karim. I took the course with you before Dr. Tan.
Okay, so Dr. Sahar Abdul Karim. And the other Dr. Sahar?
Sahar Najmus Sahar.
Sahar Najmus. Okay. Okay. Yeah. So who's planning to practice? Who asked me in the group to practice?
No problem. I can, if someone wants to practice, I can practice.
No, I mean, there is a list, but I mean, because I wrote the name, so one of.
No, I don't write my name before.
You didn't.
I joined late.
What?
I joined late. I joined late. If I don't write.
Okay, so I think the other Dr. Sahar will take the case. Then we will give you a case. Yeah. I mean, because she. Okay. Thank you. I will close it. Okay, Dr. Sahar.
Yes.
Yes. So are you ready for the case?
Yes, I am ready.
Yes, it's a simple one.
Inshallah.
Okay, so just we will implement what we just studied. This is a 41-year-old gentleman referred by his GP for knee pain since 6 months, which is not responding well to NSAIDs. Please advance. This is station 5, huh?
Okay. All right. Yeah.
I mean, you can take the algorithm in your hand and use it.
All right. Can I have a minute?
Yes.
Yeah.
I'd like to comment, Dr. Madonna, about the status of your brain now. So, can we start?
Yes, we can start.
I will ask you for something. Please open the algorithm and read from it. In order, I just want you to practice how to use the algorithm.
Okay, all right.
Try to do that so we will be sure that we're going the right way.
Okay. Okay. Good morning, Mr. Max. I'm Dr. Sahar. I'm one of the doctors in the clinic today. Can I just confirm your age? Is it 41 years?
Yes, doctor. Right.
All right. Well, I've gathered from the letter from your GP that I received that you've been suffering from knee pain since the last 6 months. Can you tell me more about it?
Yes, doctor. I have this joint pain since actually 9 months, but in the last 6 months, I thought it would be something that is temporary and it would start to improve, but it never happened, and the pain is still there. Actually, it's not a severe pain, but it's pain that agonizing me all the time. Okay, and I'm taking the painkiller that control it a little bit, but I can't get right of it at all.
Okay, I'm so sorry to hear about it, but we'll try our best to get to the cause of it. Can you tell me, is it both the knees or it's limited to just one knee?
It's actually one knee, doctor.
Okay, so the right or the left?
The left.
Okay, so as you told me, it started for 9 months, and do you think it has progressed? It has become more severe, or it's been the same?
I would say it has a little bit progressed, little bit.
Little bit, okay. Is there any associated numbness or weakness in your legs?
Numbness or weakness, no, doctor.
No, okay, all right. Any stiffness associated?
Stiffness, yes, doctor. I have some stiffness.
Stiffness, and for how long does it last?
The stiffness, I would say.
When you wake up in the morning?
When I wake up, doctor, I feel it.
So how long does it stay on?
I would say maybe just 1 hour, a little bit around it.
Okay, around that. All right. So do you think it decreases with the rest?
Decreases with the rest? No, I would say that when I start to do my work, I feel better.
Okay, you feel better with work. All right. Any swelling you've noticed?
Swelling sometimes. There is minimal swelling, doctor. I feel it, and sometimes the left knee, the pain and the swelling, sometimes the left knee, sometimes the right knee. But they're not at the same time and not the same severity.
Okay. And any other joints of your hands or any other joints you think are affected as well?
Yes, sometimes, doctor. Sometimes I have swelling in my legs, in my ankle joints, and sometimes I feel it in the ankles and in the feet itself. And sometimes I have a back pain. Sometimes a back pain.
Back pain as well. Okay. Have you noticed any rash anywhere?
Yes, doctor. I have a bad rash, actually. Yes.
Can you show it to me, please? Okay. And is it itchy, this rash?
Yes, doctor. It's a little bit itchy.
And little itchy. Does it ooze? I mean, do you feel there's any discharge coming out of it?
Not really, doctor. I'm not sure.
Not. Okay. So, is this rash present even on your scalp and behind your ears?
No, it's mainly in my hands and legs, doctor.
Okay, it's on the hands and legs. Is it all right? Okay. How's your? If I may ask, how about your bowel? Do you have any loose motions or
loose motion? No.
Any blood from your back passage? No. What about your urine? No. Do you feel it's frothy or any change in color?
No, the urine, no, doctor. But I feel some pain while I'm doing the urine. There's some discharge.
Discharge, all right. And since when is this discharge?
Maybe in the last 4 or 5 months.
4 or 5 months. Okay, all right. I'll just ask a few personal questions. Whom do you live with?
I'm living with my girlfriend.
Okay. Are you sexually active?
Yes, doctor.
Okay. And sorry to ask you this, but do you use any form of contraception? As in, do you have protected sex?
No.
Any multiple partners?
No, doctor.
No. All right. Okay.
And
okay. Can I examine your knee, please?
Yes, doctor. The knee is normally looking.
Okay. And the range of movement?
Yes, there is some pain while examining the range of movement, but still it is no looks. It's
okay.
not.
No. Okay. What is your job, Mr. Max? What do you work as?
Yes, I'm working as a nurse.
Okay. All right. Just any past history of travel, recent travel?
No, doctor.
No. Any history of clots?
Blood clots? No.
No. Okay. All right. So what are your do you smoke, Mr. Max?
No, doctor. I'm not smoking.
Okay. Any use of any recreational drugs?
No, doctor.
May I know your concerns?
Yeah, doctor. My concern, what is this, doctor, and why it is not resolving? Is it rheumatoid arthritis?
Well, it's unlikely it is.
I have my mother with rheumatoid, so.
Yeah, I understand. I understand your concern, but it's unlikely that it is rheumatoid arthritis. However, we would consider it in later on. But right now, I think what you're having is it's an inflammation of the joint, which may be secondary to probably a urine infection, what you would have contacted a few months back.
Time finished, doctor.
So what?
Time finished.
Okay. Yeah. All right.
Where did you get the information that he has a urine infection months back?
No, urine discharge. You said there's a discharge.
Yeah, penile discharge.
Yeah, urethritis. Yes, sorry.
Yeah. Okay. So what's your differential diagnosis, doctor?
Well, my differential diagnosis would be reactive arthritis. I would also consider psoriatic arthritis, considering he has a rash.
Okay.
And Bessett's, I would like to consider, but
So you will say this is a seropositive arthropathy. Seronegative, sorry, arthropathy. Right?
Seronegative, yes. Seronegative.
Yes, okay. I agree with you. Okay, and I agree with your differential, but don't you think you need to take a look for the eye when you're thinking about reactive arthritis?
Yes.
So you will lose marks if you didn't look or ask about the eyes, right?
Yes.
Because as you said, you can't speak, can't see, can't climb the tree, right? What's the name of this rash?
Oh, I don't know actually.
It's called keratosis blenorrhagica. Okay.
Okay.
It is pustular. Sometimes there is some secretion. Sometimes it's dry. Some discharge. Sorry, and sometimes it's dry. It's called keratosis. Okay. Blenorrhagic. Okay.
All right.
Yes. So here the patient, if you ask the patient, please, in these cases, when you are asking about reactive arthritis, I want everyone to ask about if you notice that if you have any history of infection or severe infection after which these symptoms started. I want you to ask this question that way. If you remember any infection after which these symptoms started within the same month, or because usually it is 2 weeks to 6 weeks after infection, ask him in previous admission. Okay, previous admission. Maybe they will tell you that I was admitted for severe gastroenteritis, and 6 weeks after that, all these symptoms started. The patient sometimes can't build the relation between the things together. So help him to build this relation. Okay.
Sure. Yeah.
Okay, great. But anyway, you reach the diagnosis. You need to examine the eye. You examine the knee. You look to the rash. That's okay. Okay. So for examination, okay, for reaching the diagnosis, okay. I just need you to be more active with the patient. I know you are sleepy now, but I want you to be stronger. I want you to show the consultant that you are a strong doctor. You show sympathy and empathy, but I want you to be strong with the patient. So, hey, tell me about that. Yes, I understand you said that, but what about that? You know. So just give him the tone of the voice of. I don't like the tone of the student. Don't do that in the exam. You know what I mean? I know you are super tired now.
Yeah.
But I mean, the exam,
No, I'm super nervous.
Why actually? No, you did more than very well.
I was way too nervous. I was literally shaking actually as I was going through the station.
Okay, but is it better to shake in the course or shake in the real exam?
No, it's better here, I guess.
So try to finish all the shivering here and shaking here. Yeah, then in the exam you'll be confident.
Inshallah.
You know, actually, eventually you reach everything. You ask all the question, you catch the diagnosis, but you were very slow as well because again it's a race in station 5. Because you didn't give me you asked about the concern in the last 26 seconds. So you didn't give me an idea about what's going on and what you are going to do. And if you didn't do that, listen, the problem that the examiner, even if he wants to help you, he will not be able to do that if you didn't even give any answer about the concern. So you will lose these marks.
Sure.
Whatever what was perfect, your performance, but eventually you want to put marks for that. Did you ask about that? No, so no marks. Did you ask about the impact? No, there's no marks. You know what I mean? So you need to give yourself some time. 2 minutes remaining, ask the concern, take the marks of the concern, then go back to what you were asking, okay?
Sure.
I don't know why you all give your, there's no summarization in station 5, no time to summarize, but in station 5, please, once 2 minutes, ask the concern, try to solve it, and go back and ask more questions, no problem. Okay.
Sure.
Okay. So now again, I will continue the questioning with you. You get the differential diagnosis, and I agree with that. This is negative, and you said reactive arthritis. Okay. What do you think the treatment for reactive arthritis?
Treatment would be and starting on do this because I would like to do a swab and do a complete blood count and look for the X-ray of the joint, and then accordingly, if there is any infection, then start antibiotics and physiotherapy. And
no. There will not be current infection for now. Remember, it is not about the acute infection. It's something since 7 months or 8 months. So, and the patient maybe have no current. I agree if you want to do your analysis, but don't mention that in your management. In the management, what I want you to say here, you will say that we are going to refer the patient for physical therapy and occupational therapy. So this is the non-pharmacological, and then we will include the joints doctor. We may include the urology or the rheumatology and urology. This is we are talking to examiners, so just use the medical term, the medical name.
Sure.
And we are going to start in painkiller and non-steroidals. Okay. Then in the acute, acute phase, we are giving antibiotics. Okay. If it's in a chronic phase, okay, some patients need self-limiting. Some patients will reach up to biologics. So sometimes we give up to biologics. Don't mention that in the exam, but in the reactive arthritis, sometimes it will extend all the life. You imagine that? Sure. And sometimes very difficult to treat. So 15 to 20% of patients, it can be chronic and extend for years. But 80%, it will be self-limited and it will disappear. And the acute, we can give antibiotics and NSAIDs. Okay. So just for this slide, thank you very much, Doctor. You did very well. I like your performance actually. So usually reactive arthritis. Thank you. So 1 to 6 weeks after the acute infection, chlamydia, salmonella, shigella. So these are the types of infections. Okay, this slide will be sent to you, so no need to write anything. Asymmetrical, large joints, oligoarthritis. Can come right, left. It's in the leg, ankle, knee. Okay, rest. Keep it coming in different areas. Keep roaming in the body. Urethritis and ocular inflammation. So can B, can C, can climb the tree. Can B, can C, can climb the tree. Then there could be palmoplantar pustulosis and mouth erosion. Sometimes there's mouth erosion. So don't let the mouth erosion misguide you toward the basic disease. Okay, so it will be in your differential anyway. But remember that reactive arthritis may be associated with mouth erosion. But remember, genital answer, mouth erosion. So there is similarities. There is some similarities. But with basic disease, there will be history of blood clotting, and it will be clear ulcers, damn urethritis. There will be genital ulcers, not burning sensation with urine. Okay. For the treatment, 80% is HALA P, human leukocyte antigen B27 positive. No different treatment. Usually self-limiting, can progress to chronic arthritis in 15 to 20%. Acute phase may include antibiotic NSAIDs to manage joint symptoms. Skin similar to those used in psoriasis may be required for cutaneous feature patients. So they treat the skin lesion the same as psoriasis. So remember, you don't need to keep the name of the skin rash. You don't need to know the keratosis, rhinorrhetica. You can just use palmoplantar pustulosis if you need that. So that's it. That's it for the knee pain. We tried case before the algorithm, one after the algorithm. The second algorithm is for the shoulder. I will not discuss it because this you will receive a lecture. Dr. Ahmed will send it to your email and you can watch it in your off days. So this is what will happen. Sometimes there will be some things. I have a lecture of 1 hour or something. We give it in the free lecture or something. So in this case, we don't give it with our heavy day because in our heavy day we need to discuss some things that you didn't see or hear before. Okay, so you will receive the shoulder. Remember, for the shoulder, it's almost the same, but there is some difference. So it's the same pathway. Okay, the same pathway, but the difference is the polymyalgia rheumatica. Okay, and the avascular necrosis and the frozen shoulder. So everything will be the same as the knee, but there is a difference in causes of avascular necrosis and frozen shoulder and polymyalgia rheumatica criteria. So same algorithm with some differences, and you will receive a lecture for this part. Okay. Then again, I know you are tired. Please let me continue. Okay. The hand pain. It's the same again. This is almost the same. We will use the same patient with hand pain. We are going to laxity and stiffness as ASCT, OCD, or Socrates. Okay, 3SP, ND, and rash. Then go to laxity. I don't know why I wrote OCD, not Socrates. So does it improve with activity? Then PND, 3S, as we said very early. Then go to laxity. Okay, in the laxity, Ehlers-Danlos, so the marfan, stiffness, the beads, and mechanical, there's osteoarthritis, pseudo gout, and gout. Okay, you can add septic arthritis. You can use the same as the hemochromatosis. Septic arthritis not very common in the hand. Could be hand infection more than septic. We'll not call it septic arthritis. We'll call it hand infection. But the difference here in this algorithm, doctor, will be 2 other things. The difference will be in the hand pain. You need to ask what you mean by hand pain. I mean, hand pain will not mean all the time it's joint pain. They describe hand pain when they talk about carpal tunnel. the field of carpal tunnel, the patient will come and say, I have hand pain. When you ask him about details, he will tell you that he has this electrical feeling, he has the pain of flexing the wrist, but it's still considered as a hand pain. And another type of hand pain is the Raynaud's. If you ask the patient about Raynaud's, the patient with Raynaud's will come and say, I have hand pain. So if you went through only the stiffness and the pathway of the joints, you may miss the case. So remember, whenever you have a hand pain patient, to ask him, what do you mean by hand pain? Is it joint pain? Or is it color change with cold weather? Or is it electrical-like pain and numbness, which decrease by shakes or cold water? So 3 questions. Is it joint pain? Is it pain with the color change in cold weather? Is it electrical pain that improve with shakes? So these 3 questions are great. Yes, Dr. Madonna said her case was a case of Raynaud's as a part of wrist syndrome. So here, this is your approach. You need to ask this question. The first thing, tell me about this pain. Is it joint pain? Is it electrical pain with numbness? Is it changing the color? Again, I want you to imagine how organized you will be when you start that way. Everyone going and asking a bizarre, unorganized question, and you have this page in your mind. So you will go inside, just collect your thoughts, ask about color change. What do you mean by hand pain? Ask it, is it color change with? Is it electrical pain? Is it joint pain? If it is joint pain, remember, it still can be Raynaud's with joint pain, because Raynaud's is still part of the red pizza, right? So you can't only stop when it is a change in the Raynaud's. You will go back to the red pizza in certain stage, okay? So let's see how we can do that. But I want you first to remember the differential diagnosis of Raynaud's and the differential diagnosis of carpal tunnel. To make it easy, I didn't make it myself. This is a known mnemonics. We use cold hand because Raynaud's happen when your hand is cold, right? So remember the letters of cold hand and remember the letters of median trap. You know that carpal tunnel is trapping of the median nerve, right? So it's easy mnemonic, cold hand and median trap. Can you please all stand up and try to move? I hope nobody's sitting all the time. Please, doctor, try to stand up and move. I'm moving while talking. Try to move. I don't want you to get problem in your legs because of the prolonged sit. Please, this is just a request from a brother. Try to stand up and move your pizza leg, okay? So for the Raynaud's, cold hand, I don't want you to follow the orders of the letters, just to remember the mnemonic order. If the case is from outside hand pain, and you said, okay, if it's Raynaud's, I will put my differential off 1, 2, 3, 4. To remember the 1, 2, 3, 4 outside, I want you to write the cold hand. But you want to highlight only these yellow parts, yellow names. So the C can be cryoglobulinemia, which is not common in the exam, but still it is something that become and close the small blood vessels on the tip of your fingers and cause the Raynaud's. Very uncommon to come in the exam, and it is associated with hepatitis C. The very common and important occupational patient with Raynaud's disease, okay, not Raynaud's phenomenon, just they have a Raynaud's. And this is because the occupation, patient working in a fish shop, for example, patient working in an ice shop, patient working in anything that all the time he exposed his hand to a cold weather or cold water. So because of this exposure to the cold water, there is a continuous vasospasm of the tips of the blood vessels in the tips of his fingers, and it can cause the Raynaud's. The Raynaud's sometimes reaches ischemia, and we call it autoamputation, happened due to the ischemia, due to loss of the blood supply going to the tips of the finger. The L, which is very important, lupus. And here it is not about lupus. They just use the L because we want to point toward the connective tissue disease or dermatological disease. So when you write L, lupus, write the red pizza. All the red pizza can be associated with Raynaud's. So the L, lupus, and the red pizza. So L as a part of the red pizza. So rheumatoid arthritis, systemic lupus, systemic sclerosis, which include CRIST, okay, and polymyositis and dermatomyositis, they all can be associated with Raynaud's disease. Then drugs, the D for drugs, BBEE, okay. The B referred to beta blocker. One important, one not important. Beta blocker is important, bleomycin is not important because it is chemotherapy, which is not common to be used. But just the EE, ergot, because ergot causes vasospasm, ergot and estrogen. Ergot and estrogen. So beta blocker, bleomycin, ergot and estrogen, okay. Then hypothyroidism, it's important as a cause of Raynaud's. It can happen, not common to come in the exam, it will be difficult, but you need to know that it can cause all the hand pain. So patient with hypothyroidism have pain, it can be carpal tunnel and it can be Raynaud's. Then arterial problem, hematological arterial problem like Berger disease, atherosclerosis, there is vasospasm there is obstruction of the arteries. So this disease is causing Berger's is a disease causing ischemia with so there is blood vessels and there is thrombosis, then it will cause Raynaud's, then the end referred to not known. And this is just if you search everything and no cause for the Raynaud's, in this case we call it Raynaud's disease, and it is what it is. So I have my one nurse working with me, she had Raynaud's without anything else, and I have another doctor with me, she has Raynaud's as a part of systemic sclerosis. Okay, so both of them have Raynaud's, both of them suffering the same, but the one with the Raynaud's disease, she only had the Raynaud's. Everything else came back negative, and for the doctor, she's suffering with CT scan and the morphological change and all these problems that happen with systemic sclerosis. Okay, the last D is diabetes. So diabetes also like hypothyroidism. Diabetes can cause Raynaud's and can cause carpal tunnel. So some things share hypothyroidism and diabetes and idiopathic. So 3 things can cause the same. 3 things and 4 things actually. 4 things can cause it. It is shared between Raynaud's. The first thing is occupational. The patient can have carpal tunnel because of his job. Any person, very common in the exam, to have a patient with carpal tunnel because he's working with vibrating tools. I'm sure some of you have this case or hear about this case from any colleague. They bring a patient with hand pain. You will catch it as hand pain because of carpal tunnel. You will confirm the carpal tunnel. You will examine for carpal tunnel. You will go and exclude all the causes of carpal tunnel. And eventually, you will ask about the job. And the job, he's working as a barber. So all the time, he's catching the vibrating machine. Then, or he's working as a worker in the street with jackhammer. You know the jackhammer, this device that they make holes in the street by. So this is a jackhammer, any vibrating tool. And the people don't trimming for the gardens. It's a very common job in UK. Or even at home, when you have, in UK, in the United States, you have a garden. So you need all the time to trim your garden. So you are trimming them with the trimmers. The trimmers, all vibrating tools. You will notice that if you have carpal tunnel, it will be getting worse. And it can cause carpal tunnel itself. So there's 2 things that makes it occupational is shared between both occupational Raynaud's and occupational carpal tunnel. Diabetes mellitus can do both. hypothyroidism can do both, and it is idiopathic in both. Okay, so remember, cold hand. And the carpal tunnel, myxedema, is a part of hypothyroidism. So the M here they use for hypothyroidism, as you said. Then ethanol, alcohol can cause carpal tunnel, diabetes. Then the I for idiopathic, the A for amyloidosis. You know that amyloidosis is causing trapping of the median nerve, and the neuropathy, which is coming with. So just try to write it, median trap, and try to fill the gaps. The T for trauma, tumor, and trimming. This is trimming. I mean any job with trimming. Trimming in Arabic is taqlim al-ashya, which means that you're making it in a line, adjusting the line to the H's. Then the R for rheumatoid arthritis. So again, here it is the same lupus with connective tissue and rheumatoid arthritis. Both can cause it, right? Then something like acromegaly and pregnancy. So just try. This is you need to put an order. So let's say I have a patient with hand pain. Can you tell me about this hand pain? As to place, increasing, decreasing, acute, blah blah blah. Okay. Any stiffness, any deformity, any rash? No. Can you tell me about the nature of this pain? Is it electrical pain or is it pain in a cold weather, cold change in the fingers, colors, and pain? He said yes, it is electrical pain. Did you notice that when you shake your hands or put it in cold water, it's improving? Maybe, doctor, or I'm not sure. Or yes, that's true. Okay, can you tell me if you have any weather preference? Did you gain any weight? Do you have hard stool? So 3 questions only for screening. No, doctor. Okay, do you drink excessive alcohol or something? No, doctor. I'm just social drinker. Was you diagnosed before? Were you diagnosed before by high blood sugar or something? No, doctor. I'm not diabetic. Okay, do you have any weight loss? Excessive weight loss? Do you have any frothy urine, pins and needles in different area other than your hands? This is for amyloidosis, for example. Okay, and he said no. Okay, then and this will cover both neuropathy and amyloidosis. Then do you have any trauma to your hand? Do you have any history of tumors? Okay, what's your job? Do you use any trimming devices at home or at work? Do you have any joints pain in your hands, deformities, swelling, or rheumatoid arthritis? Did you notice any change in the size of the ring and shoes and coarse feature of the face? When was your last menstrual period? Do you have a partner? Are you sexually active? I'm sorry for this private question. This is for pregnancy. For cryoglobulinemia in Raynaud's, how to ask? Okay, I will ask you, was you diagnosed with? Do you have any rash? Because cryoglobulinemia has its own rash. You can see a rash like burn, okay, in the chin of the tibia. Do you have any history of liver disease? Was you diagnosed with any problem with the liver for hepatitis C? What's your job, sir? Do you use your hand in cold water or ice or something? Did you notice it's worse at work? Okay, do you have any joints problem? Then ask about the red circle. Do you have any weather preference? Do you take any medication like beta blockers and estrogen and this stuff? Do you smoke, sir? Any history of any blood clot in your body? Okay, do you have any pain, changing color of the tips of your feet, for example? Any severe pain in the fingers of your the toes of your feet? This is because of atherosclerosis and Berger disease. Usually they have this in their feet. Then do you have diabetes? So these are the questions if it is a hand pain. I know I'm fast. I know you are tired. I'm just trying to make the stuff a little bit faster in order to, you will read it later on and you'll feel it simple. Not after 5 hours, but at least now you will feel it as simple. Later on when you read it, you are very familiar with the right side and the left side, you will know how to ask and what are the things that you need to follow. Okay? Give me the okay that you are okay with this algorithm and you understand the principle now. I'm not expecting you to get it perfectly, but at least you understand the principle. So when you review that, you know how to review it and how to use the algorithm. Okay, good. Oh, just give me a second. Okay, so this is Dr. Ibrahim. If Dr. Ibrahim will not take the case, Dr. Amr Amin. I know that by the end of the day, not everyone is still able to take the case because most of the time. So Dr. Ibrahim first. Dr. Ibrahim, are you there? I can see you. Thank you, Dr. Imamo. I don't know what's your real name. It's written here, Imamo. Thank you for your nice words. Dr. Ibrahim, yes. How are you, Dr. Ibrahim?
I'm fine, Dr. Tan.
How's everything?
Alhamdulillah.
Sleepy?
No.
What's the time here now?
The time is...
Where are you?
Yeah. Time is 11:15.
Ah, so it's still early.
Yeah.
Good. So the doctor from Pakistan now is 2 a.m. I think, or 1:15. So I think the people in Saudi Arabia can spend 2 hours more, right?
Yes.
Because
have night duty.
Oh, really? Okay. Okay, so let's go through. No, we are almost done. We will have only this case and another topic I'll discuss, then we are done. So it's 6 hours as I promised you. Okay, so Dr. Ibrahim, can we start this case or you need time? It's nothing. It's just patient with hand pain.
Okay, we can start. No problem. Can you give me the case?
Yeah, this is the case now, but I want you to. Can you use the algorithm, please?
Okay.
I want you, unless you know it by heart, just catch it in your hand and please use it because we want to practice how to use the algorithm. Okay.
Okay.
And I need the examiners to be fair. Try to use the algorithm yourself to correct him. Okay. This is station 5, doctor.
Yes. Can you start?
Let me start the timer. Okay. Start, doctor.
Yes. Good evening.
Good evening, doctor.
I am Dr. Ibrahim, one of the doctor in the medical admission unit today. Are you?
Yes, I'm Marian, doctor.
Marian Baron, and
yes.
you are 46 years old.
Yes, I am, doctor.
So, Miss Baran or Mr. Baran? Mrs. Baroni. Yes. We are here today to discuss your health issue and what we can do further. And I received a letter from your GP told me that you have a severe hand pain. Can you tell me more about this?
Yes, doctor. I have hand pain since 2 years.
Mm-hmm.
And this pain increasing recently.
Sorry for this. It is increasing. And since 2 years, does it improve or not?
Just when I take some painkillers and when I'm taking some precautions.
Okay. I need to ask you, what do you mean by hand pain?
Hand pain?
Mm-hmm.
Yes, I mean hand pain.
Okay. Do you mean that any joint pain or the pain is like electrical pain or any change in color?
Yes, it is joints pain, and there is also changing color actually. So I mean, when I start to warm my hands, the pain improved, but I still have the joints pain as well.
Can you tell me where is the joint that affected in your hands?
Yes, most of the joints of my hands, doctor, affected.
Sorry for that. Does it symmetrical in both hands?
In both hands, yes, it is in both hands, doctor.
And any other joint affected or not?
Yes, doctor. Sometimes I have knee pain, sometimes I have wrist pain.
Sorry for that. Do you have any associated with the swelling and any rash?
Sometimes I have a swelling and rash. Yes, I have some rash, doctor.
Can you show me this rash, please?
Yes, doctor. It is some rash in my face, in the area exposed to the sun.
I'm sorry for that. Okay. Do you have any stiffness in the morning? Yeah.
Yes, doctor. I'm always stiff in the morning.
I'm sorry for this. Okay. Do you have any soreness in your mouth?
Yes, doctor. I have mouth sores.
Any chest pain, any shortness of breath?
Sometimes, doctor. Yes, I have shortness of breath.
Do you have any frost urine?
Frost urine? Yes, doctor. I have frost urine.
Okay. So, does you have any other lumps or bumps in your body?
Lumps and bumps, no, doctor.
Or eye problems? Okay. Do you have any dry mouth, dry eyes? Or
No.
Do you have any skin tightness or difficulty in swallowing?
Yes, doctor. I have skin tightness. I have skin tightness around my mouth and in my hands as well.
Okay. Do you have any tenderness in your muscles or any rash around your eyes or upper chest?
You mean pain on touching my muscle? No.
Yeah.
No.
Do you have any recurrent miscarriage before or any previous history of blood clot?
No, doctor.
Okay. Can I ask you regarding your changing color? Can you tell me more about this changing color in hand?
Yes, doctor. It's my fingers become bluish and it become very painful, and then after a while it start to become white, then the blood come back again, and the pain feel a little bit better. So I'm trying to make my hands more warm all the time.
Okay. Can you tell me what do you do for a living?
Yes, doctor. I'm a teacher. I'm an elementary school teacher.
And how these symptoms affecting your job?
Sure, it's affecting my job. I can't write in the cold weather. I have a pain. I'm taking a lot of sick leave, doctor.
Okay, I'm sorry for this. I will try to help you regarding this. Okay. Do you have any other past medical history should I be aware of?
I have high blood pressure also recently in the last year.
What did the medication taking for this high blood pressure? Did it control?
Amlodipine and losartan.
Okay, we need this blood pressure to be controlled. Do you have any other medical problem?
No, doctor.
Do you smoke or drink alcohol?
I'm a smoker, doctor.
How many cigarettes per day?
15 cigarettes a day.
You need to quit smoking because of it harm your health. So if you don't mind, I will help you by referring to smoking cessation clinic.
Thank you, doctor.
Okay.
2 minutes remaining.
What about your last cycle?
My last cycle, doctor? It's okay. My cycle is regular.
Okay. Can you tell me what's your concern at this moment?
I want to know, doctor, what's going on with me and why I'm getting the condition getting worse.
Okay. Meanwhile, I need to examine your other body regarding this hand and need to examine the chest and abdomen. And so,
what do you want to examine exactly?
in chest, we examine for any. I'm sorry.
What?
Okay, sorry. Sorry, I will tell you regarding this condition from what we took from history. We talked with you. You have a condition called SLE and associated with renal that's causing bluish discoloration in your hand. Don't be bothered by this medical term. It is a kind of disease that affects the immunity. Instead, this immunity attack the bugs in our body, start to attack its own self, and resulting in this rash and joint pain. What we need to do is to do some blood test and also some imaging on your hand, and after that we can refer you to join doctors and even skin doctors and also the social worker and occupational health worker, the group of medical team, so as to support you regarding this. Meanwhile, we can give you painkillers. Does that make sense for you?
Yes, doctor.
Can you have any more concern?
No, doctor, I'm okay.
Okay, thank you.
Thank you, doctor.
Thank you.
Okay, doctor, time finished. What's your differential diagnosis?
Differential diagnosis is I have a picture of SLE and also picture for systemic sclerosis. In addition, I have a Raynaud phenomenon.
Systemic sclerosis and Raynaud's?
Raynaud.
Why you told the patient she has systemic lupus?
Because there is also joint pain and rash in the area of the face.
You told the patient she has systemic lupus and you are telling me it is systemic sclerosis. What's your finding?
Mixed connective disorder. Mixed connective disorder. It's a mixed connective disorder.
My question: Why you tell the patient something other than what you think?
No, sorry, because I concentrate in SLE, but it is a mixed connective disorder.
Okay.
Sorry.
Okay. It's a mixed connective. What the component?
The component is SLE and systemic sclerosis.
Okay. What do you expect to find in the chest of this patient?
Yes, in the examination of the chest, you can find fine basal crepitation.
Can you not repeat the question?
Okay.
Just
I can find basal rails like crepitation for pulmonary fibrosis. Also, I can find loud P2 for pulmonary hypertension.
Yeah. So pulmonary hypertension is the thing you are looking for, or pulmonary fibrosis, right?
Yes. Pulmonary hypertension.
Yeah, pulmonary hypertension. We know that. We said what we found in pulmonary hypertension and obstructive sleep apnea. So pulmonary hypertension can be usually with the limited disease, and the lung fibrosis with the
Systemic sclerosis.
with the diffuse, yeah, with the diffuse, right? With the diffuse disease. You agree with me?
Yeah.
Okay, so I agree with you. This patient is mixed connective tissue disease. You are a little bit slow, doctor. You wasted a lot of time in details that's not needed. You need to learn. Everyone needs to learn. In station 5, once you catch the diagnosis, do what you should do. I mean, now hand pain, Raynaud's. You ask if there is systemic lupus and there's systemic sclerosis. Done. So you went to the red circle. You catch it. Go and examine the patient. Do a full hand examination. Examine the patient. Ask the patient to open her mouth. Don't let her put the 3 fingers in the mouth anymore. This is prohibited. So before we were asking the patient to put 3 fingers in the mouth and she can't do. Okay, and the systemic sclerosis. Don't ask for that now, but just look to the patient eye. Okay, let the patient open her mouth. Look to the wrinkles around the mouth. Okay, then go to the neck, look for congested neck vein, go to the chest, check for pulmonary hypertension and pulmonary fibrosis, look to the hands, okay, go to the bending. This is hand, so you start by the hand actually. I'm talking after the hand. For the hand, you will look for signs of spontaneous ischemia, for the redness, okay, for the color change, for the joint swelling. So whatever, I will show you on one slide how to examine the hand, and you will practice that when you go to any clinical course. But you need to be very fast in examining the hand. You don't need to do full examination, but you need at least to do some partial. If you didn't do this, if you didn't examine the hand, if you didn't examine the chest, if you didn't look to the eye, if you didn't do that, they will not give you a good mark in examination. Okay, in the examination part. Eventually, you need the management plan. What's your management plan for this patient, doctor?
Yes, management plan. First, we investigate is it active disease now by doing complete count and ESR and inflammatory markers. And also, we need to do chest X-ray, I think.
High resolution CT?
And echo, high resolution CT and echo, also echocardiography.
Okay.
And
you lead the patient yourself, right? This is wrong. Please, when you go to lead the patient, remember, as I will discuss that in the communication, but remember that there is a component for the management. Don't say non-pharmacological and pharmacological because this looks very unprofessional, but just say, okay, just put in your mind that there is non-pharmacological and there is pharmacological and there is surgical, for example, okay, depending on what's the disease. So when it is non-pharmacological, you will start by the team. I will include the team of the rheumatologist, okay, and the pulmonologist, and the physical therapy and the occupational therapy. Remember, doctor, for everyone, there is a difference between occupational therapy and occupational medicine officer or occupational office. The occupational medicine office are the people that take care of your occupation, okay, and if you need to move from area to area, occupational doctor. But occupational therapy is part of the physical therapy, but it take care or concerns about your being able to do your daily activity. So usually we send the patient to physical therapy, occupational therapy. This means he's going for the same, doing physical therapy. But when we say we are going to send you to the occupational physician, okay, or occupational department, this will be the people that will take care of your job and this stuff and transferring you to the safe part of the company and this type of stuff. Okay, so this is one thing. Then, so the team is a component of the management. Then the team, including the physical therapy and occupational therapy, very important. Then I'm going to start the patient on painkillers, okay, and we will with the team of the rheumatologist and pulmonologist to check if the patient will need to be started on steroids or they will start on disease modifying or even biologics. Okay, I will also include the kidney doctor in order to take care of the kidney of the patient because peripheral in the presence of mixed connective tissue disease make sure that there is a kidney affection. This is the professional way to mention your management plan in such case. If investigation, you will say I'm going to do blood works, don't waste the time, just say basic blood works, okay, and I will request the anti-RMB, okay, for the mixed connective tissue disease. All that I will ask for the rheumatological markers, okay, investigation. That's enough. I'm going to request high resolution CT to check if there is lung fibrosis. I'll do echocardiography for pulmonary to check pulmonary hypertension, okay, whatever. So this is the way to, he will not be writing what you're saying, but they're looking for something you need to mention, and you need to mention this in professional manner. Okay. So if I thank you very much, doctor, you did well. Okay, you did well. You can diagnose, but the problem, you give the patient wrong information. You give him systemic lupus and give another question. So the examiner will not be satisfied by that. You need to say the same for both. So this is the systemic sclerosis slide as usual. What to ask and what to examine. Okay. What to ask, you need to ask about skin rash and skin tightness. You need to ask about Raynaud's. You need to ask about shortness of breath, dysphagia, abnormal bowel motions, and fluid urine and hypertension. So these are the first questions you need to ask, the blue questions, and these are for the systemic sclerosis. Then the two other question that is in the red boxes are for the mixed connective. So you ask about mouth sores and photosensitivity. You ask about tender muscles and polymyositis. So tender muscle and proximal myopathy, sorry. Tender muscles and proximal myopathy. So I'll ask about proximal myopathy, difficulty in standing from sitting position or pain in combing the hair. So again, I went in the station, found hand pain, asked, I found it is Raynaud's. Okay, when I asked about the causes of Raynaud's, I catch that it is part of rheumatological disease. I decided to check which rheumatological disease. I asked about the joint pain, there's a stiffness. Duration of stiffness, it is about 3 or 4 hours. So I went to the red circle. I asked the question, I catch systemic lupus, and I catch systemic sclerosis. So simply, this is Raynaud's as a part of mixed connective tissue disease, and that's it. Is it difficult? Can you lose any marks in such case? Then when you are in that examining the patient, you will go to the hand, and if it's affecting the tightness of the skin, affecting the hands and the mouth only, this is called limited disease. It's affecting the hands and part, actually, in the real life when you see it, it will affect the hand and part of the forearm. This is called limited disease, and usually it can be complicated with pulmonary hypertension. If it is affecting the upper arms, the skin tightness, and the trunk, we call it diffuse, and usually it is associated with fibrosis, lung fibrosis. It is more associated with lung fibrosis. Then the mouth, you will look to the small mouth, you will look for telangiectasia, you will look for possible sores. Let the patient open his mouth, look inside by your torch to see if there is mouth sores, because it can be part of systemic lupus. Telangiectasia, as a part of this red spots, okay, that can be part potential, that can be part of the crest. Then the arms, you will examine for proximal myopathy, which is part of the hemochromatosis and polymyositis. Let the patient to do like the wings, do your arms like wings, and tell them to try to push against your hands, your arms. Okay, then the chest, you will examine the pulmonary hypertension and fibrosis. Then for the lower limb, you will look for any swelling for heart failure or renal failure. These are how to examine. I'm not expecting you to keep that by heart. You will examine that in your clinical course. If you went to any clinical course, you will see a case of systemic sclerosis. But when you know all that, when you have this slide in your mind, you will examine this patient in 5 minutes and everything will be perfect. The crest syndrome component, okay, will be there is calcinosis. You see dots of calcium. You will not find it everywhere. Okay, and sclerodactyly, okay, for the fingers. Then Raynaud's, okay, Raynaud's, you see black tips of the fingers. Then telangiectasia. This is a red dots of telangiectasia. And this picture will show you some symptoms of systemic sclerosis. So when these are there, we will consider it a mixed connective tissue disease, and without, we're going with systemic sclerosis. So never stop on systemic sclerosis. As I told you, once you start the pizza, you need to eat it all. Okay, there is no diet. You started the pizza, please finish it. Okay. Okay. There is also one thing I want to show you. So this slide you received, you don't need to write. Okay. The coming case is nothing tricky about it, so we'll not practice it. We'll just discuss it because it is nothing. It is just a patient. This is a patient coming with. Just a second. This is a patient coming with a current history of rheumatoid arthritis, nothing hidden. This is 51 years old patient referred by GB for hand pain and numbness of her hands. She was prescribed NSAIDs, but recently complaining of shortness of breath. And when you ask this patient, she will tell you immediately that you have rheumatoid arthritis. Okay, so nothing hidden there. But I want you to know what's your approach for the case of rheumatoid arthritis. So here, in this case, this is a case present in rider as well. So in this case, simply, this is a rheumatoid arthritis case, and you need to know what to do with the rheumatoid arthritis. Okay, so nothing hidden. I just want you to see what it is. This is the rheumatoid nodules. This is the thinning of the skin with produces because the patient is on steroid. Usually, the patient with rheumatoid arthritis will not continue on steroids. They just have take it as bridging. But this patient in this case was in steroids for a long time. So then it was just a case of hand pain, nothing hidden. But this is the important slide. I don't know if I sent it. I will send it to you. I think because we can't write all this. So I want you to know these things by heart because they like to bring the case. It's very obvious. The patient hiding his hands and saying there is hand pain. You went inside. You start asking the same question for hand pain. Then once he said deformity, you told him show me, or rash, show me. He will get his hands out. You will know that it is rheumatoid arthritis. Remember this point. Tell him to correct the deformity because there is one case in Egypt. It looks identical, classic rheumatoid arthritis. And when you ask him to correct the deformity, he totally corrected. So this would never be rheumatoid arthritis. Okay, this can be junctional arthritis, osteoarthritis, but it is not rheumatoid because it's not correctable. So, will you think the case would be that simple? This was in the Pincer exam 6 years ago or 7 years ago. They just bring a simple case to know that it is rheumatoid arthritis, and we are done. Now there should be something hidden. They will hide shortness of breath, and they want you to catch pleural effusion. They want you to catch something hidden there, pericarditis. They want you to catch something related to the patient complication of rheumatoid arthritis. So this page will show you that the case of rheumatoid arthritis. Okay, you need to confirm the diagnosis. Ask about the hand pain, secretes, depending on what they give you. Then PND3S plus rash. Again, pain, number, deformities, swelling, stiffness, and symmetrical, then rash. So again, now you know by heart what's in the PND. Then go to the eyes. You need to read this. I will not spend much time with that. The eyes, episcleritis, painful scleritis, scleromalacia, Zika syndrome, cataract. Okay, so every patient with rheumatoid arthritis coming with blurring of vision, you need to think about the eye affection of rheumatoid disease and side effects of medication. What medication can affect the eye, rheumatoid arthritis, steroids, and chloroquine? Then the other important thing, so I'm taking it from the eyes down. I'm going down. So you will not miss what you should examine and what you should ask about. So please focus with me. I know you are tired. This is the last thing we're going to discuss. Just focus with me. So for the eyes, there is episcleritis. If there is pain, it could be scleritis. So the epi is before the scleritis. So there is no pain in the episcleritis, but there is pain in scleritis. Okay. Then scleromalacia, Zika syndrome for dry eye, cataract, as I said. The other thing, we go to the neck. The patient may have a neck pain. The problem is not the neck pain. There is something called atlantoaxial subluxation. And this can happen, and it can compress the spinal cord, and it can even kill the patient. That's why patients with rheumatoid arthritis, you should document that, and you should inform the people for anesthesia and the people in ICU when they are going to intubate the patient. Because usually when they are going to intubate the patient, they extend the knee. So they can make atlantoaxial subluxation and make the patient quadriplegic or kill him. So general anesthesia, okay, is dangerous and require extreme care in neck handling. So this is important. It is important in the exam and in the real life. Okay. Then the third thing, you'll go to the hand. You start by the hand anyway if the case of hand pain. So remember to look for how to examine the hand. I will show you on the next slide. This one, you need to examine the hand for the joint pain, and you need to examine for carpal tunnel. And you have two things for carpal tunnel. Okay. You will ask the patient if I will tap, okay, in the inner area of the wrist. Do you feel numbness and pain? This is called tunnel sign. And tunnel sign is the inverted Breyer sign. So again, tunnel and funnel, you need to look for it how the picture is. I don't know if I put it in the next slide or not. But it is two tests for the carpal tunnel. Okay, so you need to examine pins and needles. Ask about. So this is what you ask about. Ask about pins and needles for the carpal tunnel amyloidosis and Raynaud's. This you need to see in the hand. So examine the joints, carpal tunnels, and the Raynaud's. Then for the chest, you may find biliary effusion, fibrosing alveolitis, nodules, bronchiolitis, Kaplan syndrome. Okay, then kidneys, you need to consider secondary amyloidosis, so you consider frothy urine. And sometimes patients taking a lot of analgesics, so they have NSAIDs-induced renal failure. Then for the nerves, there could be peripheral neuropathy, mononeuritis, multiplex carpal tunnel syndrome, cervical myelopathy. For the heart, 40% of the patient, they may develop myocarditis and pericarditis. The anemia, and this is an important question the examiners like to ask, why the patient with rheumatoid arthritis may have anemia. So it could be anemia of chronic disease. It could be megaloblastic anemia because of methotrexate. You know that we can't give ND-MARDs, we can't give the methotrexate. So it can be anemia of chronic disease, macrocytic anemia due to folate deficiency with methotrexate. It can be association with other autoimmune disease, something like pernicious anemia, because rheumatoid arthritis is autoimmune, and any autoimmune can be associated with another autoimmune. So it could be pernicious anemia. It could be Felty syndrome, which is anemia, neutropenia, and splenomegaly, and rheumatoid arthritis. Sometimes it is NSAIDs itself causing bleeding, causing microbleeding, invisible bleeding that cause anemia. Okay, so there's many causes of anemia can come with rheumatoid arthritis. And again, these things is to study. You don't need me to help you in. This is just another complication, but in this page, this is the important part. As I told you, what to ask about, exactly what I said, the complication, you will ask about the eye. Any pain, redness in the eye, pain in the neck, hands, swelling in the hands, numbness, cold, pain in cold weather, chest, shortness, breath, cough, kidneys, frothy urine, changing the amount of the urine, nerves, pins and needles, heart, shortness, breath, orthopnea, anemia, paler than usual. That's it. Then when you are going to examine a patient, okay, this page is very helpful. Maybe not now, but later on when you go to study. Again, these things will be in your clinical courses when you go to any clinical course, but when you know that, it will make it super easy for you. For the hand, you need to look, feel, and move. Look for what? In the hand, look for swelling, look for wasting, look for deformities, ask if correctable. Let him correct the deformity. Whenever deformity, remember the word corrected. Then scars. Feel, this is important, you need to feel 2. 2T is temperature and tenderness. So write it, please. The 2T for temperature and tenderness. So you will feel by the back of your hand, the temperature. By the palm of your hand, you will do some compressing to feel if there is tenderness. So TT, tenderness and temperature. 2C for carpal tunnel syndrome and crepitations. So again, when you see in any video, you will let him move his wrist up and down, move, close and open his vest. So you can feel crepitations under your hand. Then 2S refer to the skin. There is thin skin and thick skin. If it is thin skin, it's with steroids. Thick skin, it is with mixed connective tissue disease, for example, or systemic sclerosis, right? Then the other S is swelling. So 2 S's. S, I will check the swelling. I will feel every swelling. And the other S will be for the thick skin or thin skin. So you will let the patient, you will look at his hand, you will start to palpate his joints. Okay, you will check it by temperature, you will check any tenderness of any joint. Okay, you will check the crepitations, you will check for the carpal tunnel, you will look at the skin, okay, and touch it, and you need to look for the swelling. Then tell him to do the move. Okay, let him do the moves. Just move the hands up and down, do the active hand grip, the pincer and the sealing test. You can just give the patient sealing test. I will tell you later in the neurology. And for the pincer, let the patient close his index with the thumb and try not to let you get your finger outside of this, and let him take a coin over the pillow. Remember, you will put the patient hands on pillow while examining him. Again, I don't want to waste time on that. Okay, because you will do that in the clinical and you will watch videos for that if you want on YouTube. But ask the patient to close his buttons, okay, open his buttons, okay, catch a coin. Then the arms, you need to examine the arms for nodules and proximal myopathy. You need to examine the eyes, red or blue. You need to examine the lung for fibrosis and wheezes. You need to examine the abdomen for splenomegaly and amyloidosis. For sure, you have no time for that. Remember, you just offer. I want to do that. No need. Investigations for blood count, low white blood cells. If it is, the immune suppression, Felty syndrome, urine analysis, X-ray, chest X-ray, MRI, nerve conduction. You will receive this slide. Just read it. Nothing new. Something present in all the books. So these type of things present in the book. Investigation, treatment. But this page make it simple for you when you are at the day before the exam or preparing the last week, and you want to remember that if you know exactly how to examine the patient, you carry this paper, take a look, then take your young brother and let him sleep on the bed and do all the examination on him. Then give him 5 pounds and it's okay. The treatment, physiotherapy, analgesia, bone protection, steroids, DMARDs, biological therapy, and that's it. So these are the possible management. Just read that and study it. Deformities, the only thing I put the deformities here, I don't want you to mention deformity that's not present. So don't assume that all deformities present, because if you said there is boutonniere and there is no boutonniere deformity, he will tell you, show me the boutonniere deformity. So this is called boutonniere, and read the definition for it. This is the ulnar deviation, and this is swan neck deformities. Okay, so ulnar deviation, swan neck deformities here, and boutonniere. That's it. And Z shape of the thumb. The thumb looks like Z shape. Okay, so don't mention any deformity that's not present. Association, Sjogren syndrome with rheumatoid arthritis, Felty syndrome, and other autoimmune diseases can be associated with rheumatoid arthritis. So I just said the last part very fast because rheumatoid arthritis will not be tricky. The trick is hand pain. What they mean by hand pain, what they are hiding. If it is rheumatoid arthritis, it will be about your skill and not missing anything and to answer his questions. But if they hide, remember, if they hide systemic sclerosis, never stop before eating all the pizza. If you didn't, you will miss it. Mixed connective tissue came to one of our candidates, and he was a very good one. And he was crying after going over the exam. He told me, Wallahi, Dr. I know it is mixed. And I remember to ask about mixed, and eventually I said systemic sclerosis. And he lost the exam for 3 marks. Okay, although he had bad luck in the clinical stations and the cardiology. I don't know about that. But I mean, if he just give this answer, it would get extra 5 or 6 marks and we could clear the basis. So anyway, This was his luck, but he was very sad because he missed that. He said, you pressed on that 10 times, and I forget that. So he was very sad for that. But anyway, this was his luck. So anyway, doctors, for today, I think that's enough. Otherwise, my vocal cords, well, I will lose my vocal cords. So tomorrow will be at the same time. So now